Again, keep in mind with decap BTLS, deformities, eviscerations, contusions, abrasions, avulsions, penetrations, burns, lacerations, tenderness and swelling. As we do our trauma assessment from the head to toe or a focus assessment to the kill zones, we want to verbalize what we're looking for. In some cases, an evisceration is not pertinent or relevant to a head injury, but more towards the abdomen. But the idea is that we're looking for deformities, abrasions, avulsions, lacerations, contusions, discolorations, deformities, and the like wherever we're going as far as using the head to toe examination. Now we're going to discuss about spinal cord injuries and spinal motion restriction. We understand that the head and the skull is attached to the spinal cord, which makes up the exoskeleton. So potentially a head injury could also indicate that the patient may also have something going on with their spinal cord. So keep in mind that if you're treating somebody with a head injury, we may have to also immobilize the spine. Now, spinal motion restriction is more of a type of spectrum of how we're going to care for a patient with a suspected spinal cord injury. In some cases, we may use a spine board, and in other cases, we may just use the spinal or C-collar without a spine board. Please understand and review your local protocols as to this is where you'd be treating your patients. Here we see our diagram of the actual removed bony surfaces of the skull and vertebral column. And what is left then is the cerebrum, the cerebellum, which is slightly darker gray, and we can see the brain stem. And the brain stem is then severed as it penetrates through what's called the foramen magnum, and then continues down through the spinal column. And what we see is these nerves coming off the spinal column from central, and they attach themselves to peripheral nerves. These ones run out towards the body and other organs. And as we move down towards the tailbone area, we can see that most of this exits through the spinal column and around the lower thoracic and lumbar vertebrae, and then just kind of fan out like a tail, which we call a cauda equina. Now, our spinal cord and brain is not intertwined in here. It is just basically a spinal column, our vertebral column, and it shows us the curvatures of our spine, but the 7 cervical vertebrae, our 12 thoracic, our 5 lumbar, and then we have a sacral, and what's missing is just that small little portion, that tail end of the coccygeal, where it's pretty much all fused, and that sacrospinal column or vertebral bodies actually form part of the posterior aspect of our pelvic girdle. What's interesting to note is that if we look from this side view, is that we can see small holes along that spinal cord, and we're missing the intervertebral disc, but those small holes that are just on the posterior aspect, if we're looking at it from this lateral approach, is where our spinal nerves would come out to meet the peripheral nerves. These are some mechanisms where we tend to fall, and it's just telling you how we flex, extend, overflex, and separate the spinal column. And this separation and overflexing or overbending can traumatize the spinal column that runs within the vertebral column. As a result, you can have a complete dissection of the spinal cord, which is not shown here, but it would just basically be entirely red throughout this entire picture. It also can manifest itself, a spinal cord injury can manifest itself in these other areas where we show indication of red is where it's injured. The person to our far right that's injured half of that vertebral column from right to left would present more of a stroke-like pattern with paralysis and potentially numbness, weakness, or tingling or loss of sensory on that half of the body. we look towards the center, we would have more of an anterior displacement. So we'd have both sides affected with some motor inability. And then when we look at the far right, left column, that far left one, it's a mixture of sensory and motor issues. All right. Here we're showing you mechanism of a frontal collision. The patient may have separated the windshield a little bit with their body and head. They would then suspect kind of frontal damage where the head went up and over if they were not restrained by shoulder and lap harness, no airbags deployed, contact into the windshield steering wheel, as well as being thrown back after the abrupt collision would maybe cause whiplashing, overextension, and flexion of the neck, causing damage to the spinal column. What we know that they would complain of is pain, potentially along the midline, where we would feel out either the cervical vertebrae, thoracic vertebrae, lumbar vertebrae, sacral and coccyx. So as we palpate along that vertebral column, we're pressing along the midlines, along that bony ridge, to make sure that those bones all line up perfectly and they don't misalign in any way from right to left, laterally, or anterior posteriorly where they step off and there's an obvious deformity where it's popping or protruding outwards. So pain, tenderness, deformities. There may be other soft tissue injury. They may complain about weakness, numbness, tingling, paralysis. And that one other thing was loss of bowel and bladder control. Now for our assessment, again, use your trauma assessment sheet for the National Registry. Doing a good head-to-toe examination, getting an accurate history, delegating the vital signs, providing an airway, reestablishing breaths at a current and a normal rate for that age, providing oxygenation if the SATs are not higher than 94, and so on. We're going to perform your neurological assessment every 5 minutes if your patient is unstable. Pupillary checks, hand grasp, pulse, motor, and sensory to the upper extremities as well as the lower extremities. Can they wiggle their toes? Can they move their feet a little? This is the pulse and sensory and circulation intact distally. Here we have a flow diagram. If you like this, please review this. Please look over your text. Look at the different equipment and just remember that we have many different types of immobilization devices. C-collars, backboards, strapping, they all differ. We need to become very versed, very accustomed, very well trained in utilizing wooden backboards, plastic backboards, metal backboards. Straps that hook up, Velcro straps that we use called a spider, and then long straps that we just tease through and thread through the openings in the spine board. We also have different devices to secure the head and immobilize the spinal column to the backboard. So just understand that the ones that we use in class may or may not be the ones you may see on an ambulance or used in the field. Please familiarize yourself, but ideally it's the same concept.